Thank you all for joining us for today's webinar, Risk Made Real, Communicating Contraceptive Risk for Adolescent Providers. My name is Jessica Monmany, and I am the Senior Education Associate at ARHP. I will be moderating today's webinar. Before we begin, I would like to share how you can receive continuing education credits for this webinar. In order to receive credit, you must take the pre- and post-test. If you have not yet taken the pre-test, please click the link provided to you in the reminder email or via the webinar's chat box. You are also welcome to use the chat and question box to ask questions throughout the webinar, which our presenters will answer at the end. About an hour after the conclusion of the webinar, you will receive an email from Caitlin Borthwitz, ARHP's Communication and Education Associate, with a link to the post-test survey. Your continuing education certificate will be generated upon completion of that survey. In 4 weeks, you will receive another email with a link to a follow-up evaluation. We ask that you complete this evaluation to let us know how you've incorporated what you've learned during this webinar into your work. Completing the pre- and post-test, as well as this follow-up evaluation, helps ARHP ensure we continue to meet your educational needs and interests. Thank you in advance for your time and feedback. At this time, I would like to introduce Jackie Catal, today's presenter. Jackie Catal is a co-founder of Nursing Students for Sexual and Reproductive Health, as well as the founding member of the Oregon Health and Sciences University chapter in Portland, Oregon. She's a family nurse practitioner in Portland, providing women's and trans reproductive and hormonal health care. Jackie has a strong commitment to adolescent reproductive health care, and she's spent the last 15 years educating teens about sexuality. Jackie seeks to include appropriate and evidence-based sexual health care for every patient she sees. She attended Linfield College for a bachelor's degree in theater before going on to OHSU, where she received her master's degree in nursing. We're thrilled to have Jackie with us today, and I'll hand it over to her. Jackie, you have the floor.
Thank you. Can you hear me okay?
Yep.
Okay, I just wanted to make sure. So this is an education session that's made possible through an independent educational grant from Merck. And here are our disclosures for the panel that provided support when making this webinar. So I have nothing to disclose, and you can see the other providers or the other panelists and the past have other things that may or may not be disclosed. Next slide, please. The learning objectives are that we're going to identify aspects of adolescent brain development and how it influences decision making, identify factors affecting misperceptions and their influence on adolescent patients' contraceptive choices, defining risk in different ways, and demonstrating how we can effectively communicate during our visits with our patients. Next slide, please. By the end of this activity, you'll be able to identify aspects of adolescent brain development and how it influences their decision making, and you'll be able to identify some factors that are making some misperceptions maybe happen, and things that you can talk about during the visit to make people feel better about the contraceptive choices that they're making. Next slide, please. So let's talk about risk first. And if you've attended any of the other webinars, I'm sorry to do this again, but some people are new and haven't been to any of the other webinars about risk, so I'm going to assume that we're starting fresh from the same place. Next slide. So the definition of risk is a danger or a hazard, and also the probability of suffering harm. Sometimes people perceive that something is a harm to them, and other people might perceive that that thing is actually a benefit. So, for example, if a method gives somebody amenorrhea, it may be something that some patients like, and it might be defined as a benefit, actually, and some people might define that as a risk and something that they don't like. So you have to not only know that there are things that are actually risky, but some people perceive things as risky and other people may not. Next slide. Consequences of risk misperception. Why is it important for us to communicate effectively about contraceptive risks and benefits? Well, as you may know, almost half of pregnancies in the United States are unintended, about 45% based on 2011 data. And almost half of the unintended pregnancies each year in the U.S. occur in women who are using contraception. However, when we dig deeper into that number, we found out that about 95% of those people who have an unintended pregnancy weren't using their contraceptive method correctly. And only 5% of women that got pregnant unintendedly were using their contraception correctly and consistently. So we know that if we can help people understand their risks and how to take their methods, we can improve the risk or the rate of unintended pregnancy as we go about. And this is especially effective or helpful in teenagers or adolescents as we talk to them in the office, helping them understand the risks of not using their method correctly and consistency and what might happen if they don't use it well. Some things also increase the chance of women not using their method as effectively. For example, requiring that we do a pelvic exam before starting the pill, telling people to initiate their pills on a Sunday or their method on a Sunday, which delays them starting it. Sometimes people really take the package inserts and start reading them, and some of the package inserts are dated, and so people are maybe thinking that there's more risk than there actually is. And I think that people equate the risks of oral contraceptives, especially of those with, that are the same as hormone replacement. And so maybe they have a mother or an aunt or grandma who's taking hormone replacement, and those people are giving them incorrect information, assuming that birth control pills might have the same risks as their hormone replacement. And then also there's, of course, a lack of access to contraception. As we know, it's harder for teenagers to get to the clinic necessarily and necessarily get in to see somebody in a timely manner. Sometimes there's transportation issues, or there are school issues where they can't leave, or parents that they don't want to talk to, so they won't ask them to bring them to the clinic, for example. And then finally, not refilling things for an entire year so that the teenager has to go back to the pharmacy over and over again. Next slide, please. So to get a sense of the probability of suffering harm, certain risk calculations are used. There are some commonly used risk calculations that you should understand as you discuss risks associated with contraceptive methods. There's absolute risk, relative risk, and odds ratio, and we'll define these separately so you can understand what is going on. Next slide, please. This next slide is a polling question. So I'm not exactly sure how to do the poll. I'm sorry, I'm not on the technology side. But the question is, which of the following is correct definition of absolute risk? A, B, or C? And you can see these here. So I'll take a moment and let you guys answer the poll. You're doing a good job. About half of you have voted so far. Okay, now the poll is closed. So it looks like about 42% of people say that a percent B, that the percent likelihood that an event will happen is what the definition of absolute risk is. But actually the definition is C, percent of people in a group who experience a discrete event. Hold on one moment here. So let's talk about absolute risk. Absolute risk is the same as incidence and provides the rate of occurrence of a condition or disease in a population group exposed to a specific hazard, infection, trauma, or other event. In other words, it's the risk that an individual faces rather than the relative change in risk. A very low absolute risk means that the person will probably not experience that event. So for example, if you tell somebody of reproductive age who's under the age of 35, the total number of people at risk are just the group of people who are females under the age of 35, and we tell them you would have a 1 in a million chance of this happening, and that is their absolute risk. Next slide, please. Then there's relative risk, and this is a little bit more complicated because it's the probability of an event in one group divided by the probability of the event in another group. So it reflects the relative likelihood of developing the outcome. Importantly, the relative risk must be calculated using incidence rates, which requires a prospective study design. So to be a little bit more straightforward about it, if you have one group of people that's under the age of 35, reproductive age, and they want to take oral contraceptives, and they have no other risk factors other than being a female just floating out in the world, then their risk of getting a blood clot is 3 out of 100,000. if you have another group of people that are under the age of 35, but that group of women smoke cigarettes, then their risk of getting a blood clot is 9 out of 100,000. So the group of people that smokes, their relative risk of having a blood clot is about twice to 3 times higher. They have a 2 times relative risk than the group of people who are non-smokers. So you're comparing 2 different groups that have 2 different issues going on, but have something that's similar together. Next slide, please. So relative risk values that exceed 1 indicate an increased likelihood or risk of an outcome. In contrast, relative risk values that are less than 1 are interpreted as decreased risk or likelihood of an outcome. The confidence interval, which is shown by the horizontal line under each triangle, indicates the reliability of the estimate of relative risk calculation. The wider confidence intervals indicate that less precision in the estimate of risk. So a 95% confidence interval, which is a longer line, indicates that there is a certainty of 95% of the probability that the estimated value of relative risk is included in the range. So you can see on this slide that we have here, you can see if it's less than 1 and it has a large confidence interval, that it's going to be less risky and we're going to be more sure of that. If it favors harm, it's going to be more risky, and if it has a bigger confidence interval, it's going to be more risky for the patient. So confidence intervals, like the one in the center there, that cross the 1 on the vertical axis are considered not statistically significant and indicate that the relative risk is not associated with increased risk of either harm or protection. So the bigger the sample size is, the more patients you have in a study, shows you better what confidence we have and can show if we're more or less confident of the outcome. Next slide. So what's an odds ratio? An odds ratio is similar to relative risk. It's the ratio of the odds of an event in one group divided by the odds in another group. Relative risk can be calculated for cohort studies because the underlying incidence of the condition under the study is known. For case control studies, the underlying incidence is not known, so the relative risk cannot be calculated. So instead, we use an odds ratio. Next slide. So odds are expressed in terms of the percent of likelihood that an event will happen. For example, if you think a horse has a 25% chance of winning the race, the odds are 3 to 1 against winning. Alternatively, this can be expressed as a 75% chance of losing and a 25% chance of winning. When the odds are 9 to 1 against a horse on the racetrack, it means that the horse has a 10% chance or a 1 in 10 chance of winning the race. Next slide. So it can be misleading to examine only the relative risks or the odds ratios in determining risk associated with specific intervention or treatment. So if you tell a patient, you have twice likelihood chance of getting a blood clot, that's really going to freak your patients out. But if you tell them in an easier way with absolute risk or with numbers, you could say, you know, a person that's not a smoker has a 3 out of 10,000 chance, and a person that is a smoker has a 9 out of 10,000 chance of getting a clot. That sounds a lot less scary and doesn't, and I think is a little bit more understandable when we're talking to patients in the exam room. If you double the risk of a rare event, the likelihood of the event is still very rare. Next slide. So many factors can affect an individual's perception of risks associated with contraceptives, including individual factors, lack of understanding statistics, which is like me because I'm really bad at statistics, and I hope that I explain statistics well. It's something that's very intimidating to me. Framing effects, so the way that you talk about things can make people feel more positively or negatively toward that thing. Media influence, of course, or people that are surrounding this person can influence their decisions on what things may be they're willing to try or willing not to try. The design, quality, and duration of a particular study, and psychological, cultural, historical, and social factors will also play into all of this as well. So it's important to kind of read the audience and figure out the best ways to talk to this patient to make sure that they understand what the risks are and what the benefits are. Next slide. So we also know that there's a big stigma related to contraception, and especially when we're talking about adolescents, there's a huge stigma related to contraception. You know, I actually just had a patient the other day that came into my office, and she came in and I said, so it looks like you're here to talk about birth control today. What do you think you have heard about? What would you like to talk about? Or do you want me to just kind of tell you everything that's available to you? And she started to cry. And I said, oh my gosh, what's going on? Are you okay? And she said, I just feel so pressured into making this decision. I feel like my boyfriend and my mom don't trust me, and I just feel really slutty. And I just think that if I get on birth control, that everyone's just going to know that I'm having sex, and it's going to make me just feel even worse about myself. And that was something that I was really not expecting her to say. I was expecting just like other visits for her to be like, oh, I just want to try the pill, you know, a very simple answer. And so it's interesting because for her, she had internalized a lot of stigma around taking birth control and how that was going to make her look to other people in her life. And so I think that that's an interesting thing to think about. And then also there's a lot of historical events, slavery, eugenics, coercion, forced sterilization in various communities that we're working with. And the parents or relatives of some of our patients have experienced these things especially strongly, and that can really tarnish some methods for some patients that come in because their mom has told them absolutely do not use the IUD, or absolutely you shouldn't use Depo, it's going to make you fat, things like that. And so I think there's a lot of historical events, personal history, and family situations to kind of make these decisions harder for teenagers. And then they, also want to be using it for various reasons, and that can be hard to kind of balance out those pros and cons. Next slide. So risk communication in contraceptive counseling. Next slide. So what makes effective communication about contraceptives? The published literature has demonstrated the value of two different types of communication. There's relational communication and there's task-oriented communication. So I think we as providers struggle with this the most tangibly in the office when we're working with patients. We have task-oriented things that we have to do. We have to make sure we chart and code and write the right things and put the right amount of points and review of systems and all these things that we have to make sure are in the chart that are detail-oriented so that we can get paid at the end of the day. But we also have to look at the person in front of us and be kind to providers and make sure that we understand what they're looking for and give them what they need in the end so that they can choose the best method for them. This is not about me making a choice for a patient. This is about me helping the patient decide what's going to work best for them and what sounds best to them in their lives at that time. So I think that when we look at this, I think the most important thing is that we shouldn't always assume that effectiveness, so meaning that they're not going to get pregnant, is the most important feature for all teenagers. Sometimes teenagers want to use birth control to make their acne better or their periods better because they're really crazy or heavy or painful. And so sometimes they may choose the pill instead of a LARC, and that feels really, I think it feels a little bit crushing to providers like me who want them to have the most effective method and not get pregnant. But I also want to remind you that this is not about me or you as a provider, this is about the patient, and we need to talk to them about the method that's going to work best for them, and then figure out too, like, how can we talk to them about the risk and realize that the pill is less effective if you're not taking it as well? How can we tell them the best way to take their method so that it's the most effective for them and they also don't get pregnant if they don't want to be pregnant? So I think that's an important thing to think about. Next slide. So understanding the risks and how to communicate them is important, and establishing a trusting environment is really, really important. Rapport, especially with teenagers, I think is #1 in the room. You may have them in for the first time and you really want them to go out the door with a method in hand or a method at the pharmacy or a method in uterus or in arm. But sometimes you're not going to get that the first time around. Sometimes they just have to look at you and make sure that they seem to like you. And they may not tell you the whole story and they may not feel comfortable with you yet. And so it's important to try to be as patient as you possibly can and know that sometimes no method is unfortunately what's going to happen at the end of the visit, even though that's what you were hoping for, possibly. Putting risks into context, making sure that you sort of understand the community that you're working with so that you don't say or assume things that may not be true. And also remember that discussing a risk may make it salient. And so, if you say, ooh, now that you've decided to take the pill, you have a risk of getting a blood clot, that may be like, oh, I didn't know that I had that risk, and that might lead to a whole new discussion. So sometimes saying something about a risk can make people start to really worry about it, and that can make it hard to finish off your visit as well or quickly as you feel like you want it to. Next slide. So when you're talking about information about risk, make sure that you talk about risk reduction. Like I said, if somebody chooses a pill, talk to them about taking it at the same time every day and how that can reduce the risk of getting pregnant without wanting to be pregnant. Talking about, how do you remember things? What's best for you? Let's talk about how we can problem solve and make this the most effective method for you and make it work as best as possible. Remember to present the absolute risk. You have a 1 out of a million chance, you have a 1 out of 5 chance of something happening, rather than saying you're twice as likely to get something, or putting in an odds. It's 75% chance risk, because that makes it really hard for teens to understand. I mean, it makes it hard for everyone to understand in a lot of cases, but for teens especially, they're not necessarily thinking about it in that way. And then also be aware of framing effects. The way that you say things can make things sound really scary. So for example, the message can influence an individual's perception of risk by presenting it favorably rather than unfavorably. So you could say, you have a 10% chance of dying if you take this medication, or a 90% chance of living if you take this medication. If you say you have a 10% chance of dying, of course that's going to make people think twice about if they want to take this method or not. And then also have multiple complementary tools available so they can touch things, they can see things, they can understand what's going on. Next slide. So then we also have comparative risk. And you can see here just by this slide, we can compare risk to a lot of different things. We could say that it's, taking birth control is very safe. In fact, it's way safer than driving a car, because your chance of death by taking birth control pills is 3 out of 100,000 chance, and then your chance of dying by driving a car is 20 out of 100,000. You can make things sound really good or really scary depending on what you compare them to. And I think that's something that you learn as you're going along, what kind of things you feel are important to mention and what things you feel might help motivate or unmotivate your patients to do something that you want to. And I think it's important to remember not to try to coerce teenagers, especially because we have a particular outcome in mind. So next slide, and this next slide is a polling question. So what percentage of students in grades 9 to 12 indicated that they had not yet had sex? So of the 9 to 12th graders who have not had sex, how many percent of them have not had sex yet? So I'll go ahead and answer the question. So it looks like the majority of people said that, that 46% had not yet had sex, and it's actually 53%. So you guys are really close. So 53% of teens from 9th to 12th grade have not had sex yet, which I think is important to remember that, we perceive that all teenagers are having sex. That's what they do because they're bored and because it's fun and all these things. But a lot of teens don't have sex until after they're done with high school. So that's important for us to remember. So now let's talk about communicating risk to adolescents. Next slide. In this section, we'll focus on communicating risk to adolescents and talk about specific things that are happening in their brains and maybe some ways we can talk to teens in a little bit easier way so they can understand. So we know that different things are happening in the teenage brain than the adult brain. And we know that the networks in the limbic system, which controls emotional regulation, earlier maturing, or prolonged development, and compared with other brain areas, is one part of the process that's going on. So we have that, the limbic system, and then we have the prefrontal cortex, which controls cognitive control and inhibition, and it's slower developing than the other brain areas. So even though they may be able to mature earlier or emotionally regulate themselves well, it doesn't mean that they're necessarily able to inhibit or control their responses as easily. And however, the immature prefrontal cortex alone cannot account for adolescent choices always, because children would then be predicted to be very great risk takers, and they're not always. Instead, adolescent risk-taking behavior is shaped by the combination of many factors, including genetic versus environmental factors, hormones, and growth. So there's a lot of things going on in the adolescent brain. Next slide. When counseling an adolescent patient, keep in mind that her developmental stage affects her ability to think abstractly and undermines her ability to understand risk. By age 15, the reasoning ability of most adolescents is fully developed for hypothetical situations, while their ability to reason is less advanced for real-life events. There is substantial evidence to suggest that adolescents engage in risky behaviors despite knowing and understanding the risks involved. The decision to engage in risky behaviors such as unprotected intercourse is best understood within the framework of cold, like quote-unquote cold and quote-unquote hot cognitive processes. Cold cognition refers to the thought processes that occur under conditions of low emotion or arousal, while hot cognition is associated with strong feelings and high arousal. These influences day-to-day decision. These effective influences affect day-to-day decisions and result in decisions that are made at the level of kind of a gut feeling for the most part, and not within the conscious awareness. So, of course, if somebody decides to have unprotected intercourse, it's because they're in a hot cognitive process. They're feeling strong feelings, they're feeling highly aroused, and they're not going to stop and be like, I wonder what this is going to do to me later. They don't really go to that place. During the adolescent transition, regulatory systems are brought under control of central executive functions with a fully coordinated and controlled set of executive functions developing in the later years of adolescence. Early adolescence is characterized by the onset of puberty with emotional arousability, sensation seeking, and the focus on immediate rewards or gratification. There's an increase in reward sensitivity in the limbic system, probably due to the neurological and hormonal changes of puberty. And we know that the limbic system is the first one to kind of fully develop, and other things follow behind. So the reward pathway is really strong, and rewards versus consequences kind of can really guide the patient's decision-making process. Next slide. So compared to adults and children, the reward center in the adolescents is more activated for anticipation of reward. And I think the post-test has a question about this. And so the part of the basal forebrain of the hypothalamus, the nucleus accumbens, is the part of the brain that compares rewards and is more activated for the anticipation of a reward. This translates into greater emotional satisfaction when a risk produces a desired outcome, especially within a social context. So if a teenager takes a risk and it works out in their favor, then they're more likely to do it again because they like that feeling of taking the risk and then also being rewarded for it. Youth may cognitively know better, but may make a less desirable choice based on the emotional context and the immediate rewards because the more mature limbic system wins over the prefrontal control system. Next slide. So if emotion and rewards rule for teenagers, how can we as healthcare providers approach risk counseling? And this is really challenging. So I think emphasizing the risk of peers on their choices and decisions and figuring out who or what are positive influences on these people can be a helpful way to kind of frame things. So they might come in and say, you know, my best friend is using the Nexplanon and she loves it. And I might grab onto that and be like, oh, wow, like what does she love about it? And kind of talk about it in a positive way because she really thinks about her peer in a really positive way and thought that she made a really good decision for herself. So sometimes that's a good way to talk to teens about, you know, the choices that they can make that are going to be positive for them. And also showing them how to handle peer pressure and changing social circles. So you might find out that everyone in her group has tried Depo and has gained a bunch of weight. But for her, of all the methods, Depo sounds like the best. And so talking about how, you know, if your friend came up to you and said, oh, you chose Depo, why did you do that? We all told you that it was such a bad method. And maybe talking through that scenario and role-playing a little bit so that she can understand how to be strong in her choice and make sure that she feels good about it. And then also using some hands-on models so people can really understand, you know, what they're dealing with. Next slide. So there's some core values to promote youth-friendly clinical services. There's beneficence, autonomy, justice, and confidentiality. And I think of all of these, I feel like, at least in the room, the most pressing of these is confidentiality. Because I think that teenagers, depending on the state you live in, of course, really have to deal with confidentiality issues. And who knows what's going to happen over the next little bit of time. I live in Oregon and I work in Oregon, and we have a super incredible rules around contraceptive information and STD testing for teenagers and for youth, and we don't have a lot of hurdles to jump over or barriers to deal with, and I think that that's really different in different states. And so being able to assure that the patient is going to have confidentiality in your office is really important. And I think understanding the laws around adolescence in your state is also really important. These things change from time to time, and it's really important to be able to know what you're allowed to say, what you're not allowed to say, who you're supposed to say it in front of, who needs to sign forms or agree to things. If the patient can go to the pharmacy on their own, for example, or if they have to go with their parents, if forms are going to be sent to their house with insurance information on it. I think that these things can make teens really nervous, and it's one barrier for people not to come in and see you because they think the parents are going to find out no matter what happens. And so I think that's really important to remember. And, you know, the other ones, making sure that, you know, the individual can make their own choice, that they can make an equal and fair choice, and also making sure that they figure out how they can take positive action to help others is also really important when we're doing clinical services. And sometimes those things are easier said than done, especially in the, in the exam room, depending on where you live and what you're doing. Next slide. So, I think it's really important, of course, to treat everybody with dignity, but I think adolescents especially are having a lot of assumptions thrown at them, either by their teachers, their friends, their parents, themselves, and just talking about how, hey, you've come here to talk about, birth control today, and it sounds like you really want to take care of your health, and that's really awesome. So I think that you've made a great choice, and I'm so glad you're here. I think saying things like that can really reinforce that they'll, stay and make a choice, or at least come back and talk to you again. And then also being able to talk about sensitive topics. You're going to be talking about sexual health. You're going to be talking about substance abuse. You might be talking about safety or interpersonal violence. You may be talking about mental health and issues that face teenagers in all those regards. And all those things can affect the risks that teenagers take and the behaviors that they choose to do. So you want to make sure that you help them make their own decision the best you can so that they can feel good about the choice that they've made. I think it's important to ask about chaperones. I think a lot of teenagers come in and they bring their parents, or they'll bring their friend or their boyfriend or girlfriend with them. And so just making sure to ask if they want that person present in the room during the exam, and also asking if they want a different medical professional other than yourself in the exam as a quote-unquote, another witness. And sometimes they feel better with more people in the room, and I think sometimes they feel not as comfortable with more people in the room. Make sure that you talk about why you're doing testing and what the testing involves. Let them know if they're going to need to do a pelvic exam or not, if there's other ways they could do it. Give them a choice if they're able to, so that way they can feel as comfortable as possible when they're in the room with you. And be sensitive to different populations. You have teens that have been pregnant before, there are teens that are parenting, there are sexual and gender minorities, there's HIV positive teens, there's ethnic minorities, there's survivors of sexual and physical assault. So all these things can definitely play into the unknown factor sometimes that you have in the room sitting in front of you. You don't always know these things, and these things aren't always going to be divulged to you, especially at the beginning if this is the first time you're meeting somebody. And so I just assume as best as I can that this person possibly has lots of stuff going on, and all of those things are going to make this decision either easier or harder for this patient, and I want to help them navigate that stuff. Next slide, please. So even though the slide says, if possible, set time to speak to these alone, I would say it's really important. I think it's a really, really critical piece. Even if somebody brings their mom or brings their boyfriend, I do my very best to get them in the room alone, or if I can't get them in the room alone, at least make an excuse to bring them into the hallway and talk to them alone. Usually my excuse is, hey, I need to do a urine pregnancy test, even though you said you're not sexually active, it's just part of our protocols. We always do it for everybody. Or I need to make sure that I take your vital signs so I can get them, and our scale is in the bathroom over here, so I need to take you over in this direction for a minute. Mom or boyfriend, hang out here for a second and let me do that, and we'll come right back. Sometimes, and actually this is what I very commonly do here in Oregon because my law supports me so well, is that I'll tell the mom, sister, aunt, whoever's in the room with this patient, I'll say, hey, I'm really glad that you're here, and I'm so excited that you've come to support your daughter, son, niece, whatever. But I just want to let you know the first part of this visit, I'll have you in the room, and at the end, I always make sure that the teenager gets time by themselves, so I'm going to kick you out. So just giving them that expectation and letting them know, if you have questions or concerns right now, I really want to hear them because I want to make sure I understand the full story. But at the end, I'm always just going to give them a little privacy so they can learn how to be a patient on their own and learn how to navigate this healthcare system with me. So I always let the parent know that I'm going to kick them out in the end. And I think it's worked every single time except for once when the parent refused to leave. And then I took the patient out with me to the bathroom and asked her if she felt safe, and she said she did. So that was okay. So, you know, it works most of the time if you set the expectation at the beginning that the last part of the visit is going to be a one-on-one visit, and it can help kind of make it less awkward for you in the end. So obtain a sexual history, offer a wide variety of options, offer same-day starts and insertions of things if you're giving them the option of Nexplanons or the IUD. Explain relative and absolute risk, and recommend dual protection. You know, we know that teenagers do take make risky choices sometimes, and we do know that the risk of getting an STD is higher than the regular population. So we want to make sure that we talk to them about condom use and protecting themselves against sexually transmitted diseases. We also want to screen all sexually experienced patients ages 25 and under annually for chlamydia and gonorrhea, unless the prevalence of gonorrhea in your client population is known to be less than 2%. And we also want to figure out how we can make it so we don't require a pelvic exam. And that can be really intimidating for a lot of teens and a big reason why people don't come. And if you do one pelvic exam on a person and you don't explain it very well, you can also find that their friends, they'll go and tell their friends that they had a pelvic exam, and their friends may decide not to come and see you because they're worried about having to do that. So if you need to do a pelvic exam, make sure to say, I don't always do pelvic exams, but it sounds like you have a lot of symptoms going on, and I really want to look and see what's happening here. So at least they know it's not something that you're requiring just because they're for birth control, but more because of, hey, I want to check out the problem that you're talking to me about. And also don't require a pregnancy test before offering emergency contraception. We know that emergency contraception is entirely safe for adolescent women, and if they come in and they ask for the morning after pill or Plan B or whatever they want to call it, you know, make sure that you get it for them so that they have it in their bedside table and they can take it or give it to friends as needed. Next slide. So best practices for counseling. Make sure you ask about their sexual partners in the past year. And I don't always just say, like, so tell me about your sexual partners that you had in the past year, because they're usually, that's a really overwhelming question. So I might say, do you have a sexual partner right now, or are you having sex? And they might say, no. And I'll say, okay, have you had a sexual partner maybe in the last couple of months? And they'll say, no. And I'll say, okay, well, what about in the last year? And they'll say, oh, yeah, actually, about a year ago, I broke up with my boyfriend. And so then you can ask more questions about that. So maybe not making it a big chunk, but being more specific and breaking it down can be a little bit easier for them to conceptualize and do a better answer. Make sure that if you need to, you screen for chlamydia and gonorrhea. But also I would say, too, that if a person comes to you and they say that they've never been sexually active and the reason that they're starting with birth control is because they want to make their periods better, I think it's also something that we jump right away to, like, oh, they're teenagers, they must be lying to us. Of course they're having sex and they're just not telling us about it. And so I think that we suspect a lot of people are doing things that maybe they're not just because of, you know, who they are or what they look like. And so I would just say that if somebody is trying to be honest with you, I would hope that you would try to believe them as well. And especially because, you know, doing a chlamydia and gonorrhea test isn't always free for people. And it may be in your state, but it's not always for us. And so I would just make sure that you let them know, hey, if we do this test today, it might be billed to your insurance, or, you know, if you know any details about that. Because if somebody says, I'm not at risk for chlamydia and gonorrhea, I've never been sexually active before, then if you do that test and you charge them and it costs them money, that's also going to be a barrier for them to want to come to see you in the future as well. And like I said before, let them know in advance if a pelvic exam is needed and why. Next slide. So I think another helpful tool is, and I have a box that I bring out for all my contraceptive talks for all people that come in and want to be on contraception, and it's just a box with all the different methods that are sitting in there so that I can hand them an IUD, I can hand them the ring, I can hand them the Nexplanon, and they can touch it, they can feel it, they can see how flexible or you know, what size they are, and it can make people feel better about the choices they've made. I mean, it's very often that you'll hand somebody an IUD or an Nexplanon and they'll say, oh wow, it's that small, I didn't realize it was so small. it seemed a lot bigger in my friend's arm, or other things like that. And so, having people touch things, a lot of people are very tactile learners, and it can be really helpful with devices or implants to let them know the size and the shape of the thing you're going to be giving to them. Next slide. The other thing that I think is really important is technology tools, especially with adolescents. Of course, most of the time, I wouldn't say all the time, but most of the time, teens are on their phones, on the internet all the time, looking things up. Even in the room, they'll say, oh, like, what are you talking about? And they'll look it up on their own resource at the same time that I'm talking to them about it right in front of their face. So I think that technology is something that teenagers are used to using, and they don't always necessarily have the best sources, but they definitely are using things. So suggesting things to them that are going to be good sources are really great. And I think on this slide, the thing that I use the very most with teenagers is the Bedsider app. And so it used to be that you do it on the website, but now it's an app, and you just download it from the Play Store or their App Store. And you can do it in the room, which is really nice. And it'll help people, they can look at the different methods that are out there. It's done in a really colloquial and down-to-earth way, so it's easy to understand. It's done, I think, pretty cutely as well. I like the way that they do things. And then also, there's a reminder app on there, so if they need to, they can get a text at the same time every day or every week or every month to remind them to take the pill, change their patch or their ring, or come back for depot. And so it's really nice because it's something that's very tangibly there and has a lot of really good evidence-based information. And then these other sites, too, I think are a little bit more clinical and maybe not as relevant for teenagers, but I do give people handouts from Reproductive Health Access Project as well, even though a lot of times they want a digital form of something and not a paper copy. Next page. And so I think a lot of teens are also going to be hearing things that may concern them, and they'll come in and say, oh my gosh, I read online that blah, something happened. And I think that it's important to acknowledge your patient's concern. A lot of times these things come at me, and I don't even realize that they exist. Like, I haven't heard of it yet because it comes so quickly, the information comes so fast that I haven't heard of it. And so a lot of times I have to be honest and say, I haven't heard of this. Can you show it to me? And I'll have them bring up the article or bring up the blog post or whatever. And so, telling them, hey, I'm not really sure, or this is what I know about it, and this is why it's a good study or a bad study, can be really helpful so people feel comfortable with the method they're choosing. And I think they'll read this and may decide, okay, I'm just going to stop this method, and if I get a chance, I'll go back to the office and change to something new. And during that time when they're not on anything, of course, they have a risk of getting pregnant, and they don't want to if that was their goal of birth control. So I think that's important for us to know, because as things come out, people kind of really react, and they won't take the thing they need. Next slide. So I think that the most, or the newest thing that I've seen out there is that on Facebook, there's this big study, of course, that pops up on my feed all the time, that birth control causes depression. And it was this big study, and a lot of patients are coming in and asking about it. So I put a slide or two in here just to talk about it a little bit, and we can talk about it maybe a little bit more at the end if we have time. So basically, there was a study that looked at over 1 million Danish women ages 14 to 55 for 13 years. So it was a really long study, and there was a lot of women in it. And basically, they pulled the records from the national database, and they looked at the diagnosis code and also the prescription records. And they found that there was an increased risk of depression associated with all types of hormonal contraception. So they analyzed the hormonal contraceptive use and subsequent depression in 2 different ways. They had women who had received a diagnosis of depression, and then they also saw that some women had diagnosed or had a prescription for antidepressant medications. So the risk of depression among the women using hormonal forms of birth control increased to 2.2 out of 100 women instead of the control, which was 1.7 out of 100 women who did not use hormonal birth control. So the conclusion was that some women are susceptible to depression. There are only a few, and we don't really know who, and we don't really know why, and maybe we're not sure either if the way of analyzing this is done in the most effective way. I mean, I know plenty of people that take prescription medication that's an SSRI for anxiety or OCD and not depression, but because they're pulling out data about the types of prescriptions that they're getting, this could also be inferred that they have depression when maybe they don't. Next slide. So we know that every medication has potential risks and benefits, and hormonal birth control is no exception. The study did not take into consideration many caveats. And we as providers shouldn't simply dismiss the study, but we should take an opportunity to counsel patients about birth control and depression. And just as you would talk about depression with any of your patients, I think, especially in teenagers, there's a risk of people having depression that's not reported because they don't really know what to do about it, or they just feel like they don't want to talk about it. And so making sure that we ask our patients, hey, have you been feeling more depressed lately? Have you been feeling suicidal? And they may say, yeah, I'm feeling more depressed. And so talking about that in the context of starting new hormones and saying, hey, this might make you feel more depressed, and that's not normal, so I want you to make sure you talk to me about that, because if you feel more depressed, I want to help you choose a different method. That's really important to me, that you're not feeling more sad. So, just thinking about how you can talk about that as a potential risk, and not ignoring the data, but also knowing that there's maybe some other things that kind of weren't seen as, or weren't studied as well. Next slide. So we also want to support communication with the parents of these kids. I usually ask, have you talked to your mom or your dad about your sexual health? And if not, make sure that they're in a safe place and reassure that they'll safeguard their confidentiality. Next slide. So the tips for effective communication: know your purpose, be an active listener, eliminate distractions as best you can, which is really difficult in the exam room because we know that you're getting paged or called or people are knocking on the door. So sometimes you can't totally eliminate external distractions, but do your best. Present the information in several ways and ensure understanding. Next slide. So I usually ask patients when they first come in, I'll say, it sounds like you're here to talk about hormonal methods of birth control. What do you think is the most important thing to you? And then pause and listen to what they say. They might say, I really want my acne to be better, or my periods are really horrible and I play volleyball and I can't play when I'm on my period. So then you say, okay, what I'm hearing you say is that you want your periods to be lighter. And they'll say, yeah, that's what I'm saying. Next slide. At the end, when you've talked about all these risks and benefits, you might ask them to teach back to you. So asking them what they've heard from you is a really helpful thing. And I think this is especially helpful when you're talking about bleeding inconsistencies with the implant or with an IUD. So I'll say, hey, I just want to hear what you heard about the side effects, the possible things that could happen to you if you choose the IUD. And they might say, oh, well, I heard you tell me that I would have some irregular bleeding and it would probably be really crampy. And you could say, yep, that's exactly right. So asking them to teach back to you, so that way you know that they understood what happened. It'll relieve some calls afterwards. It'll relieve some anxiety for the patient. It'll hopefully make your teaching worthwhile. Next slide. So we also want to use shared decision-making and letting patients choose the best thing for them together. So not going in the room saying, well, I think you should be on an IUD because it's the best, but rather asking the patient what they're looking for and combining those things together so that you can choose something that's going to work for her in the end. Next slide. So you want to introduce the options, describe the options, and support the patient as she considers the pros and cons and makes a decision. Next slide. There's a peer-based counseling model that is used, I think, kind of commonly, and it provides some perspective in what's most effective and least effective as far as methods go in preventing pregnancy. But sometimes it can be too directive, and I think that sometimes this model can be used to kind of push the larks and make people kind of feel guilty if they don't choose those. So it's important to talk about if effectiveness against pregnancy is the most common, or is the reason why they want to be on this method, and making sure that you talk about all of the methods equally as best you can without having a lot of bias. Next slide. This is that comparative tool, and I don't know if you've seen it before, but it's there on the ARHP website if you need to find it, and it'll be in this presentation if you look at it later. So last, I know we're getting close to the end of time, and I want to give a little time for questions, so let's talk about this case presentation. So you have an 18-year-old G1P0 college student. She presents for follow-up 1 week after her first trimester abortion. She's healthy and takes no medication. She's heterosexual with 3 previous male partners and a new partner for 1 month. Prior to the pregnancy, she used a combined oral contraception, and when asked, she reports that she would typically miss 2 to 3 pills each month. She tells you that she needs to go back on the pill because of her acne, and she believes that she can remember the daily pill. So, the first thing that wonder is the pill really the best method for her? And is talking to her about how to remember the best use of your time? And is it really going to help her achieve the goal that she wants? Next slide. So you want to clarify the goals. You want to say, how important is it to prevent pregnancy? Do you want to become pregnant again in this next year? And she tells you that preventing pregnancy is actually the most important goal, but she worries about her acne coming back. So you use peer-based counseling. You show her the chart that says the most effective and the least effective methods. And you explain to her that the typical use effectiveness rates are much higher for the top-tier methods because she doesn't have to do anything to control them. They're just there working all the time, and she doesn't have to remember them. So you explain that there are many reasons why the typical use effectiveness rate is lower for the pill, and that sometimes people forget, they run out, they don't have it available. Say she goes to spend the night at her friend's house and she doesn't take the pills with her. And sometimes feeling sick can make people not remember to take the pills too. So you talk about the basic attributes, benefits, and side effects of the various methods, and you provide an implant, a ring, an IUD, and other things for her to touch. Next page. So you ask Lolani what method seems best for her, and you let her know that if she decides to discontinue the pill and her acne returns, there are other treatments available. So she tells you that actually, after thinking about it, she would rather have the implant inserted instead. She says it would be actually a relief not to need to remember to take the pill every day, and you guys talk about how to insert it, and she decides to get it done that day. You review the risks, the benefits, and talk to her again about that abnormal bleeding pattern because it can be really surprising for some people. You talk about the need to continue to use protection against STDs, and you ask her to teach back and talk to you about the things that she heard. So that way she makes sure she likes what she's choosing. And then you put it in. Next slide. So, remembering how to assume the good and talk about risk is the best way to talk to adolescents, and understanding that sometimes their perspectives are different because of their brain development, but that's okay, and we need to take time to try to understand that and help them make the best decisions we can. So with that, there's a couple minutes left for questions.
Thank you, Jackie, for that excellent presentation. I'll now start reading questions for you to answer. Our first one is from Shannon, who asks, how do you manage care when a younger patient's mom or dad won't leave the room?
Oh, that's a great question. So what I say, because I live in Oregon, and this is probably going to be different if I live in a different state, but because I live in Oregon, I say the law requires that I give your daughter or son some time alone in the room, so I want to make sure that you share with me all of your concerns before you leave, because I feel like you're probably worried about something. Sometimes that works, and sometimes I'll say, the law in my state tells me that I can tell you, mom and dad, as well as the patient in front of me, that you can actually come and see me without your parents' permission at any age. So I just want to remind you that that's something that's allowed. If you feel like you want to come back and make your own appointment, that you can. And so I let the parents know that right away so they didn't hear that. And then I say, is there something that you're concerned about that didn't get brought up or that you're worrying about? And, like I said, most of the time the parents are actually really relieved to leave the room. But there have been a time or two that the parent just won't leave, and I just let them know, well, your child could come back if they wanted to on their own.
Great, thank you so much. Our next question is from Tyler, who asks, how do you counsel a patient that says they don't want to get pregnant, but then also don't want a foreign thing in their body?
That's a great question, and that happens a lot, actually. So I first ask about, what about this foreign thing is freaking them out? And sometimes they don't like the process or the idea of what they have in mind of what the insertion is going to be like. So talking to them very specifically about if they choose the implant, this is how we put it in, or if you choose the IUD, this is how you put it in, and tell them it's a quick procedure and it'll last you a long time, or it's going to be pretty crampy and I can't really sugarcoat that, but once it's in, it's working really well. So sometimes it's actually the fear of the insertion itself, and sometimes they really just don't want that thing in there. And so then you talk to them about how to make the method that they're going to choose the most effective. So can you remember it at the same time every day? What are these things that are barriers to you to making this method as effective as possible? And usually you kind of can whittle down what the real concern is and make it as effective as possible for that person, and they choose what they really want.
Great, thank you. Our third question is from Alexis, who says, I work with a lot of Latina patients, and they think that IUD will, quote-unquote, de-virginize them.
Yeah.
Have you encountered that in your practice, and can you tell me how you would address that?
That is such a good question. And actually, interestingly, I just had a mom come in with her daughter to have me write a letter that said that she was still a virgin because she had had the IUD put in, and culturally it was very important that she was remaining a virgin. And so I had to write this like bogus, well, I thought it was bogus letter about that. So it's like really interesting that you bring this up. So basically, I talked to them about what the hymen actually is, and that it's something that stretches often and is often broken, quote unquote broken, before they've had anything sexual happen to them. And I just explained their anatomy a little bit better to help them understand what that means, and that letting them know that, you know, they may choose not to have sex for a long time, but we still do pelvic exams on them starting at age 21 for a pap smear. And so just letting them know, you know, what we're doing and also what the hymen actually does and what that means, I think sometimes can help alleviate some of those fears. And sometimes you get to write a bogus letter that they can bring home and say that they're still a virgin.
Perfect, thanks. Our next question is from Camilla, who asks, how do you explain typical use versus ideal use for contraceptives to adolescents?
Oh yeah, that's really great. So I basically say, like, okay, so it sounds like you want to use the pill. And most people, when they choose the pill, will use it typically, quote unquote typically. And that means that they might forget to take it at the same time every day. Maybe they would leave it at their house one day and they would forget. They would take it at 9 one day and then noon another day, or they'd sleep it and forget. So that's kind of typically using the pill. And if you wanted to use it perfectly, ideally, then you would take it exactly at the same time every day. So if you use it typically, then, you know, 11 out of 100 teenagers are going to get pregnant in the first year. But if you use it perfectly, then 6 out of 100 teenagers are going to get pregnant in the first year. So I just try to let them know why it might be typical versus ideal, and then what the consequences are if they don't take it as perfectly as they can.
Great, perfect. So that is our last question. So would you like to review the key points for us, Jackie?
Yeah. So, you know, like I said before, it's really important to use shared decision making and not push any messages because you think it would be best for that particular patient. Try to use peer-based counseling if the most important thing to them is effectiveness, so they understand which methods are going to work the very best for them. Because of their brain development, they're less risk avoidant than adults, and they may not make the best decisions. And so talking to them about how to think things through is going to be the best thing you can do, even though sometimes the heat of the moment is going to take over. It's helpful to show them how to handle peer pressure and point out the effects of maybe what their friends are going to say. And then next slide. Ooh, is that it? I thought there was one more.
Nope, you have summarized beautifully for us. Thank you so much.
Awesome. Thank you.
And thank you again for joining us. Before we end
you.
today's webinar, oh, yeah, thank you. I'd like to share a few additional reminders. In about an hour, you will receive an email from Caitlin Borthwitz containing a link to the post-test survey. Your CME or nursing CE certificate will be generated at the end of that survey. Be sure to print the certificate before closing the internet browser. If you have questions, just email us at education@arhp.org. A recording of today's webinar will be posted shortly on arhp.org, where you can also find recordings of the previous webinars in the series regarding communicating contraceptive risk. arhp.org is also where you can register for the final webinar in this series, taking place on December 14th. Thank you again for joining us today. We hope you will take part in other live and on-demand sessions hosted by ARHP.